Hey guys, and welcome back. In this video, we're gonna talk about the anatomy of the hand. Now, starting to talk about the hand, we need to talk about the bones, and then the joints, and then the muscles, and then the spaces, and then any clinical notes. Now, what are the bones that make your hand? The hand is made by carpal bones, because that part in Latin means carpus, it's your rest. So we have carpal bones, and then we have metacarpals, and then we have phalanges. In the phalanges, we have 3 phalanges for each one of the fingers, and for the thumb, we have only 2, the distal and the proximal phalanges. And for the others, we have proximal, middle, and distal phalanges, and one we call it phalanx. Now, the metacarpals are the bones that makes the carpals to meet the phalanges. This is how I used to memorize the difference between carpals and metacarpals when I was in my first year studying anatomy. So metacarpals are those bones that are between the phalanges and the carpals. Now, each one of the metacarpals, they have base, they have a shaft, and they have heads. All right? Now, we're going to move to the carpal bones. The carpal bones are 8 in number. We have proximal row and we have distal row. We have 4 and 4. So if we want to know how to memorize them, we can remember this mnemonic, which is she looks too pretty, try to catch her. So this is the bones arranged proximal to distal. So this is the proximal row, this is the distal row, lateral to medial. All right, so if I look at a hand in anatomically correct position, and I know that my radius is the lateral, all right, and this is my proximal, it means I have to move and start from this bone. 1, 2, 3, and 4 is on top of it, and then I have 5, 6, 7, 8. All right, so the first one is the scaphoid. All right, the first one is scaphoid, scaphoid. And scaphoid looks like boat, and this is what scaphoid means in Latin. It's a boat shaped. If you guys look here, you will feel like it looks like a boat. So this is the scaphoid. This is a radius, all right? So this is a proximal row. This is lateral because anatomically my thumb should be away, all right? So, sorry. So this is the scaphoid, the first bone. And then the second one is L, she looks, the lunate, crescent shaped. All right, so if you look at the scaphoid followed by lunate, so this is what lunate means in Latin. It's a crescent shaped. All right, so scaphoid and then lunate. And then that is followed by she looks to triquetrum, which is this one down here. Triquetrum means it has 3 borders and 3 angles. All right, triquetrum. So this is the, if we move proximally, we have scaphoid, lunate, and then triquetrum down, and pisiform on top of it. She looks too pretty. Pisiform is on top of it. If you look at the dorsum of the hand, it's difficult that you see the pisiform. You cannot see it from the back of your hand. You can see it even bulging in your hand right now. If you try to touch medially your carpus, you will find a bone that is bulging up. This is your pisiform, okay? So she looks too pretty, all right? So she, scaphoid, looks lunate, and then triquetrum, pisiform. So this is the first row. And then the second row, again, lateral to medial, it's gonna be try to catch her. Try to, trapezium, trapezoid, all right? The twin. So the second row is going to be trapezium, trapezoid. So if you look at this, trapezium, trapezoid, they are twin. Trapezium followed by trapezoid, lateral to medial. So trapezium and then followed by trapezoid. And then you have the capitate hamate, catch her, capitate hamate. So the one that is in the center is capitate. The one is in the center is capitate. Capitate means head. So you can remember that your head is in the center. So capitate and then hamate, because it looks like a hook. It has a hook here, which is important for the attachment of flexor retinaculum. And so capitate hamate. All right. So and here the trapezium trapezoid. Okay, so she looks too pretty, scaphoid, lunate, triquetrum pisiform, and then try to catch her. It's going to be trapezium, trapezoid, capitate, hamate. All right, guys? So these are the carpal bones. Now we have the wrist joint, and we said that previously that the wrist joint, we call it the radiocarpal joint because it's predominantly between the radius and the carpals, and because we talked about how the wrist joint is a synovial joint, and the articular cartilage is made by hyaline cartilage, the articular surface I mean, and then that is lined by synovial membrane, there is synovial fluid, and that is all covered by fibrous connective tissue, and then the fibrous connective tissue should be supported externally by ligaments. So the ligaments would be that we have in the wrist joint. We have the palmar radiocarpal, palmar ulnocarpal, dorsal radiocarpal, radial collateral, ulnar collateral. So if you find a ligament from the radius to the carpals at that side, you will call this is your radiocarpal ligament, all right, collateral. Sorry, this is the radial collateral ligament. It's going to be between the radius and the carpals. If it's in the radial side, we call it radial collateral. Any ligaments, you guys, we have in sides of any joint, we call them collaterals because they give collateral kind of support, extra kind of support. So the radial collateral will be near to the radius, or this is also called lateral collateral, the same thing we are following everywhere, and we will have a ligament between the ulna and the carpals. If it's laterally, we call it ulnar collateral. All right, so outside we have radial collateral and ulnar collateral, and then we have ligaments between the radius and the carpal themselves, so we call them radiocarpal. So dorsal, we are on the dorsal side now, so we call it dorsal radiocarpal. And from the palmar side, if you find a ligament from the radius to the carpals, we call them palmar radiocarpal ligament. And if it's from the ulna, we call it palmar ulnocarpal ligament. All right, so and from the sides we call them the collaterals. All right. Now we need to talk about an important thing, which is the anatomical snuff box. Right, so this is the anatomical snuff box. It's a depression made by the tendons of the lateral walls here, and they call it a snuff box because that used to be this is the tobacco snuff box, the tobacco powder snuff box. So they used to put the powder here and snuff it. All right, so that's why here this is a depression. We call it anatomical snuff box. Now we need to know the boundaries, we need to know the content, the floor, the superficial structure. So how would we know the boundaries? All right, so how would we know the boundaries? So I have a nice story between the Polycis family. So we have a Polycis family, two brothers, the Extensor Polycis brothers. One is longus and one is brevis. All right, so he was making fun of his little brother. So he told him, you're not going to follow me all the way to the hand. So you're going to be alone. So, and then their cousin, which is abductor Polycis longus, abductor because he's a cousin from another parents, but it's the same Polycis family. He decided to go to this little guy and join him, so they became together, and then they left the Extensor Polycis longus alone. All right, so remember, abductor Polycis longus, Extensor Polycis brevis, they are moving together, and the Extensor Polycis longus tendon is moving alone. So if you guys try now to contract your tendons here, you're gonna find one that is in the dorsum of your hand alone. All right, bulging here, this is the Extensor Polycis longus tendon. All right, and this is alone. And if you go to the lateral side here, you will find two tendons. One of them is for the Extensor Polycis brevis, and the other one for abductor Polycis longus. All right, so try to do this, and if you find a question in exam or anything asking you what is the lateral border or the lateral boundary of the anatomical snuff box, make sure you put your hand in anatomically correct position, which means is the thumb is away from your body. You will say that the lateral border is those two guys, the Extensor Polycis brevis and the abductor Polycis longus, and the medial border is going to be your extensor pollicis longus, all right? The one that is moving alone, all right? So just make sure you're holding your hand in anatomically correct position to be able to answer that question. Now, what about the floor? The floor is mainly, you guys, made by the scaphoid bone. So this is very important because if you get a scaphoid fracture, you are going to injure the radial artery. What is the important content? It's your radial artery. You guys can now touch this area and you will be able to feel the pulsation of radial artery against the scaphoid bone. And what about the superficial? Superficially, you have the skin and you have the superficial branch of radial nerve, and also the cephalic vein is there because the venous system, you guys, we talked about the cephalic and how it is it's moving laterally. It was actually starting by the dorsal venous arch and it wraps around here, and then it starts to take all the superficial veins from your upper limb down here all the way up until you reach your point of drainage in the axillary vein up in the by piercing the clavipectoral fascia, like we said previously. All right, so here this is how you need to know about the boundaries of anatomical snuff box. Now moving on, we talked about you guys previously how the flexor muscles need to reach the stuff here in the hand in order to do flexion of the wrist, flexion of the digits or whatever. We need to know that we have a very important structure called the flexor retinaculum. The flexor retinaculum, guys, is a fibrous band that is important for the support of the tendons trying to reach there. So if that is there to support, it means the tendons of my flexor superficialis, digitorum, and profundus needs to go deep to it, plus the pollicis, of course, because we know that pollicis is separate from everyone. The digitorum is only for 4 digits and pollicis has its own muscles. So those muscles need to run deep to the flexor retinaculum down there. All right, so deep to that. However, we have structures that are passing superficial to it. And of course, remember that the palmaris longus tendon, remember the palmaris longus? This palmaris longus is going to move superficial to the retinaculum, and then you will have it attaching to the palmar aponeurosis, and we're going to talk about that aponeurosis later on. Now let's get back to the flexor retinaculum. The flexor retinaculum is connected to your medial bones and lateral bones. Remember our she looks too pretty, okay? The she was the scaphoid. Too pretty was pisiform. So you have scaphoid, you have pisiform attaching the flexor retinaculum. And try to catch her, trapezium. Her was hook of hamate. So basically that way will also help us to know the attachment of flexor retinaculum, which is coming from the first bone in the proximal row to the last bone of the proximal row, and also from the first in the distal row to the last one in the distal row. So that way you will have flexor retinaculum, and then you will have your tendons passing deep to it. Now, what are the structures that do not go deep to it? Superficial structures, and that is also can be asked, like which of the following is a superficial structure to the flexor retinaculum? You need to, guys, know that the median nerve is deep to the retinaculum, deep. Let's finish the deep structures. The deep structures are the tendons plus the median nerve. So it's a very deep, it's not a very deep, it's a deep nerve, and it's a very important information because later on we will talk about the carpal tunnel syndrome, and we will know that some people will have tightening in the flexor retinaculum, especially housewives who are doing a lot of house work. Because of overuse of their hand, they will get tightening, and that is going to press over the median nerve. Okay, so median nerve is a deep structure. Now, what are the superficial structures? Of course, the superficial structures are going to be anything other than the tendons and the median nerve, which is ulnar nerve, ulnar artery. These two, they don't go deep to the flexor retinaculum. The ulnar nerve and ulnar artery. Okay, so how can we protect them? Okay, great, fine. We have some slips of fibers coming from flexor retinaculum that are going to go and arch and until they attach themselves to the lateral carpal bones, and they are going to make a tunnel. So that tunnel is going to be the passageway for the ulnar artery and nerve. That tunnel, we call it Guyon's canal. So in the Guyon's canal, if there is tightening there, you will have a problem with the ulnar nerve and ulnar artery. But it's not in the flexor retinaculum, all right? So it's also supported. Now let's get back to superficial structures. So ulnar nerve, ulnar artery, they are not going to go deep to the flexor retinaculum down here. They are going to be superficial to it. And then you have the palmar cutaneous branches of ulnar nerve and ulnar artery, because of course, if you want to give a cutaneous innervation, you should not run deeply. All right, so you should give me my cutaneous innervation first, and then you lie deep to the retinaculum as you want. It's fine. So even though the median nerve runs deep to the retinaculum, its palmar cutaneous branch is going to pierce and come out before the median nerve proceeds. All right, and the palmaris longus tendon. This is the last structure we have. So the superficial structures that they do not run deep to the flexor retinaculum in the palmar aspect are going to be ulnar nerve, ulnar artery. So you have ulnar nerve, ulnar artery, palmar cutaneous branch of ulnar nerve, palmar cutaneous branch of median nerve, and palmaris longus tendon. These are all superficial structures to the flexor retinaculum. And the ulnar nerve and artery, yes, they do not go deep, but they have the Guyon's canal and they will run deep to it. If you guys want to see that in a cadaver, you can look at how the flexor retinaculum here is holding the tendons in down there, and then you have the ulnar nerve and artery. They do not run deep to the retinaculum, they run superficial to it, but they have the Guyon's canal, which is it's not shown here, the fibers are cut already. And also if you want to see how the median nerve goes all the way from the cubital fossa all the way up until it goes deep to the retinaculum with the tendons of flexor digitorum superficialis and profundus. All right, so that this is the median nerve, and then it splits itself, like I told you guys, the M letter to give innervation to the M letter, and the ulnar is going to give to the U that is near to your ulna. All right, and the M for the radial side, and this is going to help you to know the innervation of muscles and sensation, but we will have exceptions and we're going to talk about them now in a while. Now, what happens in the carpal tunnel syndrome, like I said, if we have a tightening in the flexor retinaculum, that is going to affect the median nerve because it runs deep to it. So you will have numbness and pain sensation in the distribution of median nerve, which is three and a half fingers. You will have 3.5 fingers supplied by the median nerve. It's rarely you get problem with the muscles because the patient is not going to let himself wait until they get muscular problems. But if that happens, you will get what they call the ape hand deformity, which means you have a problem with the muscles of the thinner eminence, because the thinner eminence it falls at the side of the median nerve. So you'll have a problem moving those muscles, so it's going to be flattened and difficult to flex that part. All right, so you will have ape hand deformity if it's very severe and not treated. All right, so this is what we mean by the carpal tunnel. Now let's move on to the extensor retinaculum. Extensor retinaculum is way easier than the flexor. It's that fibrous connective tissue that is connected to the distal bones. It's not going to be attached to the carpals like we had previously. It's going to be attached to the distal end of radius and ulna, and it's going to support the tendons reaching the dorsum of the hand. All the extensor tendons need to run deep to it, except if we have any superficial or cutaneous innervation, they are going to be superficial to it, whether it's from the radial nerve or artery. If we have superficial, then it needs to get